Hello, everybody. Thank you for your interest in this webinar. I'm Peggy O'Brien of SAMHSA's Center for Behavioral Health Statistics and Quality in the Office of Evaluation, and I'm going to be providing you with some information on what Section 223 Demonstration CCBHCs need to know about state-collected measures. Next slide, please. The intended audience for this webinar includes existing and prospective Section 223 Demonstration CCBHC staff who want to learn more about the quality measures that are both collected and reported by their demonstration states. Next slide, please. I will work my way through an overview of state-collected measures and how they are used, some key points for each measure and relevance to Section 223 CCBHCs, information on comparative rates on these measures, and I will identify some useful resources. I want to start, however, by reminding you that you are not reporting these measures. Your states do that. However, I'm going through this because how you deliver services and how you record delivery of those services will affect your performance on these state-collected and reported measures. In some instances, it also will affect your state's quality bonus program payments to you. Next slide, please. Okay, to start, I will give you a brief overview of the state-collected measures and some basic information regarding their reporting and use. Next slide, please. Some of the most critical things that you should know about the state-collected measures are covered on this slide. This includes the number of measures. There are 12 measures required of the demonstration states and 2 optional measures. This is starting in 2025. The state-collected measure results are used in the demonstration, including in the national evaluation of the demonstration, as part of quality improvement for CCBHCs, and some, but not all, in state quality bonus programs. Only the states report these measures, and they are reported for each CCBHC that is part of the demonstration in the state. Next slide, please. The state-collected measures can be roughly categorized as related to medication in some way, related to follow-up after some event, related to aspects of physical health, related to client experience of care, and related to youth who are prescribed antipsychotic medication. And the 2 measures that relate to youth prescribed antipsychotic medications are optional measures for the state. I will address each of these rough categories next. Next slide, please. So there are 4 required state-collected measures that are medication-related, although I will say that other aspects of treatment are equally or more important for some of these, and I will get into that in more detail when I address each measure individually. The measures are antidepressant medication management, adherence to antipsychotic medications for individuals with schizophrenia, use of pharmacotherapy for opioid use disorder, and follow-up care for children prescribed ADHD medication. In this chart, you can see the 4 listed, along with whether they correspond to existing measures that are part of the CMS Medicaid core set, whether they are among the measures required to be reported by state Medicaid programs for the entire state as of 2024, and their 2025 potential role or potential role in CCBHC demonstration state quality bonus programs. By way of background, the CMS Medicaid core set involves 2 sets of measures, adult and child, that are designed to be reported by each state Medicaid program for all Medicaid enrollees in the state. Beginning with measurement year 2024, which is calendar year 2024, the state Medicaid programs will all be required to report any of those measures that are either in the child set or that are in the set designated as pertaining specifically to behavioral health. All 4 of these measures listed here are among those that the states have to report statewide, regardless of CCBHC involvement, for all Medicaid enrollees starting in 2024. The final column on this chart reflects the CMS guidance on demonstration state quality bonus programs, or QBPs. Not every state will have a QBP, but most will. Some CCBHC measures are required to be included if the state has a QBP program. Some are listed as optional, and the remainder are not specifically mentioned, but there is a slight possibility a state might opt to include any measure. So NSI here means not specifically included, and OQBP means optionally included. On other slides, you will see RQBP are required for quality bonus programs. QBP is important to you because states will set performance benchmarks or thresholds of performance, which if you meet or exceed can result in receipt of by your clinic of quality bonus payments. Next slide, please. This slide lists 5 required state-collected measures that I have categorized as follow-up related. They include adult and child follow-up after hospitalization for mental illness, adult and child follow-up after emergency department visit for mental illness, adult and child follow-up after an emergency department visit for alcohol and other drug dependence. And then the other 2 are adult. One is initiation and engagement of alcohol and other drug dependence treatment, and plan all-cause readmissions rate. All 5 of these are part of the CMS Medicaid core set, and all except the plan all-cause readmissions measure are among those that the state Medicaid programs must report for all Medicaid enrollees, regardless of CCBHC status, starting this year. As you can see, 3 of these are labeled RQBP. That means that if a state has a quality bonus program as part of the CCBHC demonstration, those measures are required to be included. One is optional, OQBP, and that means that they may be included. It's optional. And there is one that is listed as NSI, not specifically included. It's possible it could be, but it's not likely. Next slide, please. So on this slide, I have combined the required state-collected physical health and experience of care measures. These include hemoglobin A1C control for patients with diabetes, the patient experience of care survey, and the youth and family experience of care survey. Only the A1C measure is part of the Medicaid core set, and it is not required of states as part of the reporting obligation for the general Medicaid program in 2024, because it's not child and it's not behavioral health focused. It is required, however, if your state has a quality bonus program under the CCBHC demonstration, that it be included as one of the measures for that QBP program. The patient experience of care and the youth and family experience of care surveys are not core set or quality bonus program related measures. Next slide, please. Finally, the 2 medications related to youth prescribed antipsychotic medications. These are optional for states under the CCBHC program, but are both in the Medicaid core set, and under that program must be reported by all states starting in 2024, regardless of CCBHC status. Neither of these is specifically included in the quality bonus payment requirements. Next slide, please. So having gone through an overview of the different measures that are both required and optional for states under the demonstration program, I'm going to move on to some key points for each state collected measure and its relevance to Section 223 Demonstration CCBHCs. Next slide, please. So the first measure is the antidepressant medication management measure. This has been a required measure in the demonstration since the beginning. It applies to clients who are ages 18 and older and is a measure of retention in antidepressant medication treatment. Next slide, please. AMM measures the percentage of clients 18 and older who are treated with an antidepressant medication, who had a diagnosis of major depression, and who remained on that antidepressant medication for a given period of time. And there are two rates that are reported. There's what's called the effective acute phase treatment, and that's the percentage of clients who remain on their medication for at least 12 weeks. And then the effective continuation phase treatment is the percentage of clients who remain on their medication for at least 6 months. Next slide, please. AMM has the following potential implications for your CCBHCs. You will want to try to build processes to facilitate clinically appropriate ongoing adherence to prescribed antidepressant medication for adults who have a major depressive disorder diagnosis and who are prescribed an antidepressant medication. This does not mean you must prescribe an antidepressant medication. It just means that you might make inquiries about adherence to the medication, um, discuss any problems underlying non-adherence to medication use, and approaches to addressing those problems. It is designed, once somebody is prescribed an antidepressant medication, to help assure that they maintain on that medication. The measure does realistically allow for gaps in medication treatment to account for washout periods if there's a change of medication. So you're going down on one medication and starting another medication and maybe a gap, or if there are gaps that result from difficulties refilling medication. Next slide, please. Adherence to antipsychotic medications for individuals with schizophrenia also has been a required measure in the demonstration for states since the beginning. It applies to clients 18 and older and is a measure of retention in antipsychotic medication treatment. So in many ways, it is like the antidepressant medication adherence measure that we just talked about. Next slide, please. The SAA measure provides the percentage of clients who are 18 and older during the measurement year who have schizophrenia or schizoaffective disorder, who were dispensed and then remained on an antipsychotic medication for at least 80% of their treatment period, and that is defined in the measure. Next slide, please. For the SAA measure, CCBHCs will want to build processes to facilitate clinically appropriate ongoing use of prescribed antipsychotic medication for adults who have a diagnosis of schizophrenia or schizoaffective disorder. They can come to you with that, or you may give them that diagnosis. The same was true for the antidepressant for the depression diagnosis, and they are prescribed an antipsychotic medication. Again, this does not mean you have to prescribe them an antipsychotic medication, but if you do, you want to make sure and follow their use of that medication. So you might make inquiries about adherence, about problems that they are having with taking the medication, and approaches to addressing those problems. Next slide, please. The third measure here related to medication is use of pharmacotherapy for opioid use disorder. It's new as a required measure for the CCBHC demonstration states. It applies to clients who are 18 to 64 years of age and is a measure of use of medication therapy or treatment for opioid use disorder, or OUD. Next slide, please. The OUD measure is the percentage of clients who are 18 to 64 with an opioid use disorder who filled a prescription for or were administered or dispensed an FDA-approved medication for the disorder during the measurement year. There are a total of 5 rates that are reported for this measure by the state. There's a total overall rate that captures any medications that are used in medication-assisted treatment or medication treatment for opioid dependence and addiction. That's how it's phrased in the measure. And then 4 separate rates representing the following types of FDA-approved drug products: buprenorphine, oral naltrexone, long-acting injectable naltrexone, and methadone. So those are the 5 rates for that. Next slide, please. To support higher rates under the OUD measure, CCBHCs can take steps to facilitate access to and clinically appropriate use of FDA-approved medications for opioid use disorder, for clients with OUD. This may include prescribing or dispensing of buprenorphine or oral or injectable naltrexone. For buprenorphine use, this will include ensuring there are adequate CCBHC providers who are trained in accordance with current federal and possibly state requirements to prescribe buprenorphine. Those requirements change over time. It also may include dispensing of methadone if the CCBHC is a licensed opioid treatment program, or OTP, that is legally able to do so. If the CCBHC is not a licensed OTP, it would require establishing close relationships with local OTPs, if there are more than one, to help facilitate access to methadone for clients who prefer that medication. Next slide, please. And this is the fifth of the measures that I've kind of lumped under medication related. Follow-up care for children prescribed attention deficit hyperactivity disorder medication has been required in the demonstration since the beginning. It applies to clients who are 6 to 12 years old and is a measure of follow-up and retention in ADHD medication treatment. Next slide, please. The ADD measure is the percentage of children who are newly prescribed an ADHD medication that have at least 3 follow-up visits within a 10-month period, one of which was within 30 days of when the first ADHD medication was dispensed. 2 rates are reported. The first is the initiation phase, and that's the percentage of children with a prescription who had 1 follow-up visit with a practitioner with prescribing authority during that 30-day initiation phase. The second rate is the continuation and maintenance phase, and that's the percentage of children with a prescription of ADHD medication who remained on the medication for at least 120 days, and in addition to the visit in the initiation phase, had at least 2 follow-ups with a practitioner within 9 months after the initiation phase ended. So the entire duration of time is a 10-month treatment period. Next slide, please. To support this measure, CCBHCs can build processes to ensure that children, those between 6 and 12, who are newly prescribed ADHD medication for ADHD, not for narcolepsy, have at least 1 follow-up visit with a provider who has prescribing authority during the initial 30 days after the prescription, and then at least 2 additional visits with any provider that is a provider who can bill for the encounter, but not necessarily a prescribing provider, within 9 months after that initial 30-day period. The follow-up visits, and I'm going to read this out on this one. You will see this kind of bullet on many of the coming slides, and I'm not going to go through all of them, but these are important details that are found in the specifications, and I'm trying to make sure that they're all the things that you need to know are on these slides, whether I read them or not. So the types of follow-up visits that are permissible here may be outpatient, community mental health center, intensive outpatient, or a partial hospitalization setting, maybe by telehealth or telephone, or maybe a health and behavior assessment or intervention. For visits after the 30-day initiation period, one of them, but not both, may be an e-visit or a virtual check-in. So as you can see, these measures are designed for a wide array of settings for outpatient follow-up, generally is what they're talking about. And so they list the types of visits and the settings where they may take place. You are CCBHCs, so you are an outpatient setting. You may also be considered a community mental health center. You may have intensive outpatient services. You may have a partial hospital setting, unlikely but possible. I'm providing you with all of this information just so you know exactly what kind of settings count for the follow-up. Next slide, please. Okay, I'm going to move into the measures I have identified as follow-up measures. There are 3 state-collected measures explicitly related to follow-up, each with separately specified adult and child requirements, although there are great similarities between the adult and child. So I'm treating them together here. All of these are measures of care coordination and follow-up after either hospitalization or an ED visit related to mental or substance use conditions. The 3 adult measures are all applicable to clients who are 18 and older. The follow-up for children after hospitalization or after an ED visit for mental illness apply to those who are 6 to 17 years of age. And I'll note the age difference for the substance use disorder measure when I get to that one. So I'm going to start here with an overview of the approach to the follow-up after hospitalization for mental illness measures. Next slide, please. So this measure, the follow-up after hospitalization for mental illness, looks at the percentage of discharges for clients in the relevant age group. And you'll see here I have 18 and older, and then in brackets and in red, 6 to 17, who were hospitalized for treatment of selected mental illness or intentional self-harm diagnoses, and who had a follow-up visit with a mental health provider. There are 2 rates for this measure. One is the percentage of discharges where follow-up occurred within 30 days of discharge, and the percentage of discharges for which the client received follow-up within 7 days after discharge. Next slide, please. For the measures of follow-up after hospitalization for a mental illness, ideally you would have a process to alert you if a client has been hospitalized for a mental health related condition or intentional self-harm. You would make contact with the hospital, or they would make contact with you, and you would know when the person is being discharged. You then would have a process in place to ensure the client is seen for an outpatient follow-up visit within 7 days of their discharge, and if not 7 days, at least within 30 days. I would note, however, that for quality bonus program purposes, you will need to meet both whatever threshold your state sets for the 7 and 30-day requirements. Visits on the day of discharge from the hospital are not counted, unlike the follow-up from the ED visits that I'll talk about in a minute. The follow-up visit, that is, should be with a mental health provider. And again, it may be in an outpatient community mental health center, intensive outpatient, or partial hospitalization setting. It can be by telehealth or telephone. It may include an observation visit, transitional care management, psychiatric collaborative care management, or electroconvulsive therapy. Next slide, please. This and the next set of adult and child measures relate to follow-up after an emergency department visit. This one is for mental illness-related ED visits, and the next one is for substance use-related ED visits. Next slide, please. The key difference here compared to the follow-up after hospitalization measure is that the rates of follow-up after an ED visit permit the follow-up to be on the same day as the ED visit. Hence, if you have, when you have a 30-day follow-up, you're looking at data or a time period that goes 31 days. And then for the 7-day follow-up, it's actually an 8-day period. So it's the date of the discharge from the ED plus 7 days after or 30 days after. Next slide, please. For the follow-up after ED visit for a mental health or intentional self-harm diagnosis, you should have a process in place to alert you if a client has been seen in the ED for mental illness or intentional self-harm. Then you should have a process in place to ensure the client is seen for an outpatient follow-up within 7 days, and if not 7 days, within 30 days. The billing for the follow-up visit should have a principal that is a first listed diagnosis of a mental health disorder or intentional self-harm. That way it will be connected with the original visit in the emergency department. The visit may be with any practitioner who can bill for the service and may be in an outpatient, community mental health center, intensive outpatient, or partial hospitalization setting. It may be by telehealth, telephone, or e-visit. May include an observation visit, transitional care management, psychiatric collaborative care management, RECT. Next slide, please. And then this is the follow-up after an emergency department visit for substance use. And you will see that the ages for non-adults here includes only those ages 13 through 17. Next slide, please. There's very little difference in the general description of this measure and the last one that related to ED visits for mental health conditions. This one does require principal diagnosis, so diagnosis in the primary position, the first diagnosis of substance use disorder, or any diagnosis of a drug overdose from the ED visit. So the diagnosis could be anywhere in a range from first to whatever the last one is that they provide. Next slide, please. As before, you should have a process to alert you if a client has been seen in the ED for a substance use disorder or drug overdose, and have a process in place to ensure the client is seen for an outpatient follow-up visit or pharmacotherapy dispensing event within 7 days, and if not 7 days, within 30 days. The billing for the follow-up visit may either have any diagnosis, but with a mental health provider, or any diagnosis of SUD, substance use, or drug overdose with any provider who can bill for that service. Settings may be outpatient, intensive outpatient, partial hospitalization, community mental health center, or non-residential substance abuse treatment facility setting. It may be an observation visit, maybe by telehealth, telephone, or e-visit. Visits that involve any diagnosis of SUD, substance use, or drug overdose also may be with a peer support service or an opioid treatment service, that is an OTP, that bills monthly or weekly. Other allowable services include a substance use or SUD service, a behavioral health screening or assessment for SUD or mental health, or a pharmacotherapy dispensing event or medication treatment event. Next slide, please. The fourth measure that I've categorized as follow-up is a measure of initiation and engagement of substance use disorder treatment. It is applicable to clients 18 and older. It is designed to encourage initiation of and engagement in SUD treatment after the identification of the start of a first or new episode of SUD. And this measure has been in place in the demonstration required for states since the beginning of the demonstration. Next slide, please. The IET measure is the percentage of new substance use disorder episodes that result in treatment initiation and engagement. There are 2 rates. The first rate of initiation is the percentage of new SUD episodes that result in treatment initiation through an inpatient SUD admission, outpatient visit, intensive outpatient encounter, partial hospitalization, telehealth visit, or medication treatment within 14 days. So the episode, which may be a first episode, or it may be simply a new episode that is recurrent from a while back. And it is based on that, looking forward 14 days. The visit has to occur during that 14-day period for initiation. And then engagement is the percentage of new set episodes that have evidence of treatment engagement within 34 days of initiation. So they build on each other: identification, initiation, and engagement. Next slide, please. As a CCBHC, you will want to build processes to facilitate ongoing care for individuals who are newly identified with an SUD or enter a new episode of SUD, including the initiation visit within 14 days and another engagement visit within 34 days after that. The initial identification visit, which is pre-initiation, may be inpatient, outpatient, or in a range of other settings, and often will be outside the CCBHC. It could be an emergency department, an OTP, or something else. If it is inpatient, that will also count as the initiation visit that's required within 14 days. Otherwise, the initiation visit must not be on the same day as that identification event where they identified the new set episode. Otherwise, initiation or engagement visits may be in an outpatient, intensive outpatient, partial hospitalization, non-residential substance abuse treatment facility, or a community mental health center, maybe by telehealth, telephone, or e-visit, virtual check-in visit. Can be a substance use disorder service, an observation visit, a weekly or monthly OTP service, an alcohol use disorder medication treatment dispensing event, if the diagnosis is alcohol use disorder, or an opioid use disorder medication treatment dispensing event, if the diagnosis is OUD. So medication treatment services must match the diagnostic category of the encounter that identified the episode to count towards engagement. Next slide, please. The last required state-collected measure that I lumped under follow-up is plan all-cause readmissions. It applies to clients who are 18 to 64 years of age and is designed to assess unnecessary acute readmissions for any reason. So to be more explicit, does the CCBHC standard of care coordination, and follow-up, is it sufficient to keep readmissions within an expected range? The calculation of this measure is fundamentally different from the others, but you do not need to worry about that because you are not calculating it. The state will. Next slide, please. PCR, or plan all-cause readmissions, is the number of acute inpatient and observation stays during the measurement year that were followed by an unplanned acute readmission for any diagnosis within 30 days, and the predicted probability of an acute readmission. So data are reported in the following three categories: the count of index hospital stays. So that's the first hospitalization that you're measuring from. The count of observed 30-day readmissions. Were they readmitted within 30 days? And then the count of expected 30-day readmissions, which is a calculation that you do not need to worry about. It is done by the state. Next slide, please. As a CCBHC, you will want to build processes to help clients avoid unnecessary, unplanned readmissions within 30 days of an initial acute inpatient or observation stay. The initial hospitalizations need not pertain to mental or substance use disorders. Rather, they can be for any cause. Thus, if a CCBHC client is hospitalized either for a physical or behavioral health condition, the provision of post-hospitalization support and follow-up may help prevent a repeat hospitalization or readmission. Next slide, please. The hemoglobin A1C control for patients with diabetes is new as a required measure in the demonstration. It applies to clients who are 18 to 75 years and is a measure of ongoing assessment of a critical physical health condition. Next slide, please. HBD calculates the percentage of clients ages 18 to 75 with diabetes, either type 1 or type 2, whose hemoglobin A1C was at the following levels during the measurement year. The first rate is indicated as control, and that means it was less than 8%. The second rate is poor control, and that is greater than 9%. Next slide, please. So, one fundamental thing that your CCBHC can do here is to know which of the clients in the CCBHC have diabetes, and ensure that you include that diagnosis in their medical record. CCBHCs should monitor A1C levels either within the CCBHC or via coordination with the person's primary care provider to ensure that levels are being monitored. If you're monitoring internally, the CCBHC will want to ensure that levels are appropriately recorded in the CCBHC's medical record for that individual with the date of the test. If your state is using one of a series of non-billable codes to track those results in administrative data so that they can pull it from the administrative data, you need to use those codes that they are using to track results. There's going to be, when I get to the resources section, I will provide you with resources and separate information on finding those codes in what are called value sets. The value sets generally code based on the level, so less than 7% ranging up to over 9%. As you're able to do so, the CCBHC will want to provide supportive services to help individuals control their diabetes. So, for instance, if psychiatric medications are contributing to the metabolic syndrome or diabetes, working with the prescribing provider internally or externally to understand how to help them if that is possible. And then if there are other behavioral counseling activities that you can do, such as counseling on diet and health or exercise, that also is something to think about. Next slide, please. Both the patient and the youth family experience of care surveys have been required in the demonstration since the beginning in 2016-17. They assess client experience of care and service delivery at the CCBHC. Next slide, please. The experience of care measures use states' existing annual completion and submission of the Mental Health Statistics Improvement Program, or MISHIP, Adult Consumer Experience of Care Survey, and the Youth and Family Services Survey for Families Experience of Care Survey. And the states identify the results separately for their CCBHCs so that they can be reported. Next slide, please. For this, you should work with your state as they request to administer the surveys. Your state may or may not seek your involvement. States conduct these surveys in all kinds of ways. They may or may not directly involve providers. So that is something that your state will want to inform you about to help you make sure that people are responding. Next slide, please. So we're now at the last two measures, both of which are optional for the states to report under the CCBHC program. The first is use of first-line psychosocial care for children and adolescents on antipsychotics. It applies to clients who are ages 1 through 17 years and encourages use of psychosocial care prior to medication in clinically appropriate circumstances. I'm going to stop and just mention for a second that the reason that this measure is optional and the next one is optional, which also relates to use of antipsychotic medications in children and adolescents, is that often CCBHCs do not have a sufficiently large pediatric population to make reporting this as useful as it is for the other measures. So next slide, please. This is the measure of the percentage of children and adolescents who had a new prescription for an antipsychotic medication and had documentation of psychosocial care as a first-line treatment. Next slide, please. So the APP measure, you can help support your state if they do decide to report this as a CCBHC measure by building processes that ensure that children and adolescents who are newly prescribed an antipsychotic medication were treated first with appropriate psychosocial services at some point in the 90 days prior to the new prescription. Unless they meet any of the criteria that are listed at the bottom of this slide, there will definitely be instances where somebody may be started on an antipsychotic medication because they really need it at that point without having had any psychosocial care in the past 90 days. So the following are criteria that more or less exclude people from having to have psychosocial services first. Having at least one acute inpatient encounter with a diagnosis of schizophrenia, schizoaffective disorder, bipolar disorder, other psychotic disorder, autism, or other developmental disorder during the measurement year, or at least 2 visits in an outpatient, intensive outpatient, or partial hospitalization setting on different dates with the diagnosis, any of those diagnoses during the measurement year. And the slide goes on to state further what kinds of visits, what kinds of settings they might be, or if the child or adolescent was in hospice during the measurement year, they are excluded. So I wanted to make sure that everybody understood that, yes, there's a need to try psychosocial care first for a child, especially one who's 1 to 17 years, before putting them on an antipsychotic medication, but sometimes it's unavoidable. So there are exclusions. Next slide, please. Okay. The second optional measure for states is metabolic monitoring for children and adolescents on antipsychotics. And it's aimed at making sure that key metabolic issues are followed for youth on antipsychotic medications. Next slide, please. So the APM measure is the percentage of children and adolescents who had 2 or more antipsychotic prescriptions and had metabolic testing. There are 3 rates reported. The first is the percentage who received blood glucose testing. The second is the percentage who received cholesterol testing. And the third is the percentage who received both blood glucose and cholesterol testing. Next slide, please. If your state is using this measure in the CCBHC demonstration, you might want to make sure you have a process in place to monitor youth who are receiving antipsychotic medication. It would include monitoring blood glucose and cholesterol for those individuals at least once a year, either within your CCBHC or via coordination with their primary care provider, to ensure that levels are monitored and you're reliably informed of the results. You will need to use the appropriate codes to track the monitoring. Again, in the resources section, I will go through where you can find the codes that are applicable in the value sets. And you will want to ensure that your medical team works internally or closely with any outside primary care provider to respond to problematic results that are found in the process of monitoring for blood glucose or cholesterol. Next slide, please. Okay. Now I'm going to try to give you a sense of some of the measure rates across the United States for the state collected measures that are reported as Medicaid core set measures, meaning these are rates reported for all enrollees in a state Medicaid program. not from a specific provider, the entire state, everybody who is a Medicaid eligible or Medicaid enrolled. You should be wary of expecting to be directly comparable to these rates because CCBHCs will be serving individuals with higher percentages of serious mental illness, serious emotional disturbance, and substance use disorder than are found in the general population of all Medicaid enrollees in the state. I also will warn you that the rates I am showing you were from 2022. They do not include all states, they include the majority, and they vary greatly across states. So I'm going to be showing you a range of the low and high rates across states. When I get to the resources, I will show you where this came from and where you can find it for your state. Next slide, please. Okay, so you'll notice that I am using a slide similar to what you saw at the beginning. And I am not going to read all of these, but I will read the first one, and so you get a sense of what we're dealing with here. So for the medication-related measures, starting with antidepressant medication management, in 2022, so it was measurement year or calendar year 2022, 44 states reported the acute phase rates, that is adherence during that initial short term, between 46% and 85.5%, and continuation phase rates, so the longer period, between approximately 19% and 65%. You will see that substantially fewer states reported the use of pharmacotherapy for opioid use disorder. The measure is somewhat newer, 33 states. And you will see that far more reported on the follow-up care for children prescribed ADHD medication. So you can see, I'll walk you through the ADHD one here, that for the initiation phase rates, it was between 24 and 74% compliance. And then for the continuation and maintenance phase for the ADHD medication, it ranged from 4% to 100%. So quite a range across the United States. These are by state Medicaid program for the entire state. Next slide, please. So this slide shows rates for the follow-up measures, and this gets really busy, especially for the first 3 rows, which have both information about the adult rates and the child rates, and have it for 7-day and 30-day follow-up if it was reported. So in general, for the first 4 of these, the 3 follow-up and then the initiation and engagement, 45 to 48 states reported back in 2022, and the rates were quite varied. I'm going to go down to the second row, follow-up after emergency department visit for alcohol and other drug dependence. For adults, rates ranged for 7-day follow-up. Did people get seen on an outpatient basis within 7 days after an emergency department visit for substance use disorder or drug overdose? 7-day follow-up ranged for adults from 3.3% to 54.3%. 30-day follow-up ranged from 5.8% to almost 60%. Rates of follow-up for children within 30 days ranged from 1.8% to 50%. So you can see for some of these, there's a lot of work to be done. I'm hoping that you all can help. The plan all-cause readmissions rate is reported by fewer states, and it probably will continue to be reported by fewer states because it's not going to be one of the ones that is required of all states by the Medicaid program. But in that case, lower is better, and these are ratios, so I won't try to explain them. It's complicated and requires math. Next slide, please. So The hemoglobin A1C measure was not reported in the Medicaid core set in fiscal year 2022, so there are no rates to report on that. And then, of course, the patient and youth and family experience of care surveys are not part of the Medicaid core set, so they do not have rates available in the Medicaid core set data. Next slide, please. The two child measures related to antipsychotic use among children and adolescents have been reported at fairly high rates between 47 states for psychosocial care and 45 states for metabolic monitoring. In the first case, the rates range between 27.5 and 81%. In the case of metabolic monitoring, rates range between 16.5% to 63.5%. So the reason I'm showing you this is so you know that you are not expected to get 100%, okay? Next slide, please. All right, so now I'm getting towards the end. On the next slide, I have a list of important or useful resources for you and where you can find them. Next slide, please. So these resources, and there are links here, so when you get the actual slides, you will be able to access them. The first is the 2024 technical specifications for the quality measures. You are familiar with them already. They are on our CCBHC, the SAMHSA CCBHC website. The same for the second, which is the 2024 data reporting templates. You can find that on our website, and the link is here. The next two are the fiscal year 2024 value set directories that are used by the Centers for Medicare and Medicaid, CMS, for the adult core set reporting in the first case and the child core set reporting in the second case. So I said that there will be some times when you will want to make sure that you're in alignment with what your state is expecting to see for billing codes, even though, for instance, the results codes for HbA1c is not technically billable. There are codes that go with them, just like billing codes, that you can use to indicate the levels of or results of HbA1c tests. And so those value set directories are on the CMS website, and the links are included here. Similarly, the very last set of things on this slide are the sources of the comparative rates that I went through. I know it was very exciting to listen to me read some of them. These are for the 2022 adult and child core set chart packs. That includes the results of rates of Medicaid core set measures that are reported across the country by year. And this is the most recent year for which the data are presently available. So you can go to either of these and you can see if your state reported it and what the rates were within your state, okay? And I'm giving that to you just so that you know, you get a sense of what the overall rate is in your locale. You can look it up, okay? Next slide, please. You can skip this slide and the next slide. These are both license information. All right. So thank you, everybody, for your interest in this webinar. Please send any questions that you have to the mailbox address shown in blue on this slide, CCBHC measures submission at samhsa.hhs.gov. And we will try to answer your questions as quickly as we can. Take care and have a good rest of your day. Thank you.